Yeah, Rahul, is my screen visible? Okay, thank you. So, good evening everyone, and thank you once again for inviting me for this webinar. And I'm going to talk to you about a very, very important disease, which is adrenal insufficiency, and what family physicians should know. That's the topic. Now, as Dr. Pragnesh said, it's not a glamorous topic like diabetes. Trust me, by the end of this webinar, you'll realize how common this problem is, right? It's much more common than what you think, right? And you'll also realize how commonly we are missing this very important disease and very important condition, which if treated right, it is a difference between life and death, right? This is a condition where you have the life and death involved, and this involves everybody, right from the family physician to a physician to an endocrinologist to a critical care specialist to a cardiologist to an anesthetist to a pulmonologist, anybody who is involved in patient care, rheumatologist, anybody who is involved in patient care, anything that involves use of steroids. Again, you will realize how important adrenal insufficiency is, how commonly it is misdiagnosed, how commonly it is missed as a clinical sign, as a clinical cue, and how easy it is to recognize it and how easy it is to really treat it. And that is what we are going to learn at this end of this lecture. So it is going to open your eyes to a lot of things. Trust me, I had a talk on adrenal insufficiency with my ICU people, and suddenly right now I am seeing the number of patients that I see as indoor references for diabetes, almost equal number, almost maybe not equal but little less than that, but close to that is the number of patients that I see with adrenal insufficiency. How commonly again now ICU people and other doctors are picking up this diagnosis by looking at this from a different perspective. So that's my idea. My idea is to open your eyes to this very important condition, and I'll show you some clinical examples, some real life cases also to really understand. So there are two parts of my talk. The first part is to understand the basics of adrenal insufficiency, what the entire system is, and then we'll deal with 3 clinical cases to give you 3 different examples of adrenal insufficiency to basically again open your eyes to the potential problem and how common it is to recognize and treat it. So let us start with the key messages first, and let us start with the important the important basics of adrenal and basics of adrenal insufficiency. So when you understand when you have to understand adrenal insufficiency, I take you back to your first year and second year of your MBBS, and we'll discuss what is the HPA axis, right? So HPA axis is Hypothalamic-Pituitary-Adrenal axis. Okay, so hypothalamic or hypothalamo-pituitary-adrenal axis. This is the HPA axis, right, which is commonly, very commonly taught in first year of MBBS. So this is the HPA axis, right? Now, how does it really work? How does the system really work? So at the hypothalamus, you have a hormone which is released called CRH, which is corticotrophic releasing hormone. The CRH acts on the pituitary gland to release a hormone called ACTH. Okay, so the ACTH is released by the pituitary gland, and the ACTH acts on adrenal glands. Remember, we all have 2 adrenal glands located right above the kidney. They are also known as suprarenal glands, and this ACTH acts on the adrenal cortex. Remember, it acts on the adrenal cortex, right? So it acts on the adrenal gland to release a hormone called cortisol. Okay, and this cortisol, remember, has a negative feedback. Okay, so it has a negative feedback on ACTH, also has a negative feedback on CRH. Okay, so both cortisol has negative feedback on ACTH and CRH to control the environment, control the entire system. Also remember, cortisol is a stress hormone, so any form of environmental stress, any environmental stressors will increase the CRH release from hypothalamus and ultimately lead to more cortisol production. So stress, remember, is a stress hormone. So stress can be psychological stress or physiological stress, and both these conditions will ultimately increase the cortisol secretion of the human body. So this is the basic of hypothalamic-pituitary-adrenal axis, or the HPA axis. Now, what is adrenal insufficiency? So adrenal insufficiency in very simple terms is when you have inadequate glucocorticoid or inadequate cortisol being produced by the adrenal gland, that is known as adrenal insufficiency, right? So you don't have enough enough cortisol produced by adrenal gland, right? Now remember, I am saying insufficiency, and in this condition you have to remember that it should be equal to the amount which is required by the body. If the body requires more amount and the adrenal gland is not able to produce that, that is also adrenal insufficiency, right? So whatever is required by the human body, if your body is under a lot of stress, lot of physiological stress, for example your patient is in ICU, then more cortisol is required to counter this stress, and this if this cortisol is not matched, then also you have adrenal insufficiency. So this is something you have to understand very importantly. This is a very basic fundamental principle of endocrinology, is that you have to look at the amount of hormone release based on the clinical situation and clinical context. So that is something which is important. Okay. Now adrenal insufficiency are of different types. There are three basic types of adrenal insufficiency. You have primary, secondary and tertiary. Don't worry about it. The three cases that we are going to discuss are all cases of primary, secondary and tertiary adrenal insufficiency. I'll explain to you each of these in a very simple term what they are. Okay. So primary adrenal insufficiency, so we talked about the HPA axis. So you have the hypothalamus which releases CRH, you have the pituitary gland which releases ACTH, and then you have the adrenal gland which releases cortisol. Okay. So we know this system, and we also know that there is a negative feedback. Now if there is something wrong with the adrenal gland, right, so if the disease is at the level of adrenal gland, then this is primary adrenal insufficiency. If the disease is at the pituitary gland, then it is secondary adrenal insufficiency, and if the disease is at a hypothalamus level, then it is tertiary. Okay. So when it's at the adrenal, so for example somebody has undergone an adrenal surgery, let's say somebody has a tumor of the adrenal gland and the adrenal gland has been removed because of the tumor, then that is primary adrenal insufficiency. Or you have a condition called, we all heard this condition called Addison's disease, right. So Addison's disease is either you have maybe tuberculosis of adrenal gland, or you have autoimmune disease which destroys the adrenal gland. This all lead to primary adrenal insufficiency. Let's say your disease of the pituitary gland, for example somebody has undergone a pituitary surgery, right, somebody has undergone a pituitary surgery, then it is secondary adrenal insufficiency. And somebody where there is something wrong with hypothalamus, again once again let's say there is a surgery where the hypothalamus is damaged, again that leads to, or there is let's say head injury which leads to injury of the hypothalamus, then there is tertiary adrenal insufficiency. So these are the things you have to keep in mind, and these are the things you have to be aware about. Now something which is very important and something which is extremely important, and that is going to be the basis of lot of our discussion these days today, which there are many drugs which lead to adrenal insufficiency, right, and drugs, medications, iatrogenic causes of adrenal insufficiency are very common. So drugs can also lead to primary and generally tertiary adrenal insufficiency, right. Secondary, of course, it's going to affect directly at the level of CRH rather than. So primary drugs leading to primary adrenal insufficiency are drugs like ketoconazole, right, and a commonly used antifungal. This can lead to primary adrenal insufficiency. There is a very popular anti-cancer drug for, I just saw this patient today, so that's why I am putting this, abiraterone, which is used in prostate cancer these days very commonly. That also leads to primary adrenal insufficiency. Rifampicin can also impact. So these are all drugs that can lead to primary adrenal insufficiency. tertiary adrenal insufficiency is most commonly produced by, tertiary adrenal insufficiency is something which is most commonly produced by steroids, right. So, the steroids that we give from outside, this is the most important thing, that is what I am going to talk to you about in lot of detail in this talk, and also some other drugs like, for example, megasterol, right, you would have heard this given, right, and or for example, yeah, so these are all agents that can lead to, or anabolic steroids, all these things can lead to tertiary adrenal insufficiency. Another condition, which can often, and this is something, not a drug technically, but narcotics, right. So, narcotics, like for example, a lot of people have cannabinoids, right. So, cannabis and all these things, very, very important cause of tertiary adrenal insufficiency. And one drug very commonly used, not many people know, tramadol. Tramadol also leads to adrenal insufficiency. So, these are all agents which can lead to adrenal insufficiency. The most common amongst this and most problematic amongst this are steroids. Okay. So, how do steroids lead to adrenal insufficiency? So, let us go back to this picture again of the HPA axis. Okay. Yeah. So, this is the picture of the HPA axis. Okay. And so, I told you hypothalamus releases CRH, this pituitary releases ACTH, and this releases cortisol. Now, when you give a steroid from outside, any steroid, right, whether you are giving dexamethasone or prednisolone or hydrocortisone, whatever steroid that you are giving, it's a derivative of cortisol. So, we know that cortisol leads to negative feedback. So, when you have excess of cortisol or excess of steroid, right, let us say you have high dose of dexamethasone, then dexamethasone will also inhibit the HPA axis, hence the body's own steroid production is reduced. Okay. Now, how long should the steroid be given to produce this type of adrenal insufficiency? That is something which you have to understand. So, any dose of steroid which is more than 20 milligram or equivalent of prednisolone, remember you can go to the internet and you can search for steroid dose equivalents. This is something which is easily available, right. So, what I am saying is, so prednisolone for 20 milligram will be equivalent to something around 1 to 2 milligram of dexamethasone. So, prednisolone 20 milligram or more given for more than 3 weeks leads to suppression of the HPA axis. So, patient who has been on steroid of more than 20 milligram of prednisolone for more than 3 weeks is likely to have HPA axis suppression. Or if the patient is taking prednisolone at night time, so more than 5 milligram of prednisolone for more than 2 weeks if given at night time can lead to HPA axis suppression. Or any patient who is appearing Cushingoid, right. Cushingoid means patient is having weight gain, patient is having edema, patient is having the skin has become thinner, right. So, patient has striae. So, all these moon-like faces, all these features are features of Cushing syndrome. So, if the patient is on steroid and it's already started appearing Cushingoid, in that cases also you have adrenal, you are likely to have HPA axis which is involved. Okay. So, these are very important. The corollary of this is that any patient who is on this dose, so prednisolone, right, if the prednisolone or equivalent given for more than 20 milligram, given for more than 3 weeks, then you need to taper the dose of steroid. Remember, the patient is not producing enough steroid of their own. So, when this level of steroid the patient is on, then you have to taper the dose of steroid. You have to taper it so that gradually reduce the dose of steroid. If the patient is on lesser dose, lesser period of time, then you don't need to taper. Okay. So, let us say patient is taking prednisolone for, let us say 2 weeks, let us say 10 milligram, right. So, then you don't need to taper. Okay. But if he is taking, let us say 40 milligram since 1 month, then you need to taper. Okay. So, that is the very important basic parameter, fundamental, that you have to understand. Now, let us look at, so we talked about adrenal insufficiency, right. I am going to show you clinical symptoms and signs of adrenal insufficiency in the cases that I am going to describe, because they are not that, they are sometimes more subtle and sometimes they are not recognized. So, the clinical features we'll discuss in a few minutes. But before that, let me tell you how do you make a diagnosis, right. So, the simplest the first test you have to do to diagnose adrenal insufficiency is morning serum cortisol. Okay, so this is a test which is easily available in all labs, almost all labs in India, right? You have to do a morning cortisol level. Morning cortisol level is the test. This has to be done early in the morning, right? Between 6 a.m. to 10 a.m. This is the ideal time to take the cortisol sample, and it has to be done in fasting. All these conditions are very important. It has to be done in fasting. It has to be done in the morning, and it is to be done between 6 to 10 a.m. right? So this is absolutely essential. Now this is the first test you have to do. So if I tell you that you have to do one test only, then the cortisol level is the best test to do. Now how do you interpret the result? So if the value is less than 3 microgram per deciliter, so the morning cortisol, it is definitely adrenal insufficiency. So if you have a cortisol level less than 3, it is definitely adrenal insufficiency. If it is more than 5, right, it is probably not, right. Between 3 to 5, some people have put this as 8 also. Okay, so there is one recent paper which has said that up to 8 is probably there is doubtful. Between 3 to 5 maybe, right, you might have adrenal insufficiency. This is how you broadly look at it. Again, like I said, this 5 figure is now, new studies have shown 8, right, but fine, I mean that's something which is we can debate, but what I'll say is less than 3 it is sure, and more than 8 it is definitely not, right. So in most cases, okay. So if you're not sure, ask your endocrinologist, but what I'll suggest is, if this is broadly the outline that you need to understand, okay. So less than 3, right. So first step is to do the morning cortisol level, right. So I said the first test, so when you do the HPA Axis evaluation, you do the morning cortisol, right. Now if it's less than 5, right, that means there is likelihood that the HPA Axis is compromised. So we discussed this 5 or 8, I told you that cutoff may be put. If it is between 5 to 12, right, it's not that the patient is not having adrenal insufficiency, then we need to do further testing. More than 12, you don't need to do further tests, patient is fine, right, there is no adrenal involvement at that point of time. Now if the value is between 5 to 12, you have to do the DHEAS test. DHEAS is like, so we said, we do RBS, random blood sugar, and we do HbA1c. Okay. Now RBS gives you current value, HbA1c gives you an average over last 2 to 3 weeks. 2 to 3 months, right? So it gives you an average over 3 months. Same way, cortisol is the current value, and DHEAS, this is the test, right? This is also now easily available in most labs. DHEAS is the test which gives you the status of the axis over last 2 weeks. Okay, so DHEAS is like a HbA1c, whereas cortisol is like random blood sugar, right, or FBS or RBS, right. So this is the difference that you have to understand. So if the patient is having cortisol which is in between, then you have to calculate that, you have to look at DHEAS. Now it's not just enough to see the DHEAS, because the problem with DHEAS is that DHEAS declines with age. DHEAS reduces with age. Okay, so this is an important system you have to remember. So most labs give age specific value, right. Most labs will give a table where the DHEAS at different age groups is clearly specified. However, if it's not given, then you need to check with your lab whether the value is given or not. So when you get the value, what you have to do is you have to take the DHEAS value of the patient and divide that value by the DHEAS lower limit for that age, right. And if this value is less than 1, it is definitely suggestive of adrenal insufficiency. If it is between 1 to 1.8, it is again somewhere in middle. If it's more than 1.8, it is normal, right. So for example, let's say you have a 70-year-old patient, right, and the DHEAS generally at this age is 15, right. So if your patient's DHEAS value is, for example, 30, then 30 divided by 15 is equal to 2, which is more than 1.8. So the patient, you can say, which is more than 1.8, that means you can say the patient is normal, right. If it is, let's say the value was 14, then it was less than 1, that means the HPA axis is definitely compromised, right. So this is how you can use this DHEAS ratio to see the status of the HPA axis. Now again, Dr. Preeti madam said about some proficiencies of mine for so we made actually made a Python code for this, because again gender is also different age and gender is required. So for example, we had a 25-year-old patient who is a male. The DHEAS value at that age is 53, lower limit, or sorry, the patient's value was 53. So we took the value divided by the lower limit for that age. So value came to 0.6. That means the patient's HPA axis is compromised, right? So this is, we have made a calculator. It's not currently available online. We'll put it up soon so that people can use it. We had actually made some calculators, but currently it's not available easily. So yeah. Okay. So that's basically the concept of DHEAS ratio. Now we saw second step. So second step was DHEAS ratio. I'll come to this points again. And the third step is, if the DHEAS ratio is also intermediate, then you have to do ACTH stimulation test, right? ACTH stimulation test will be done by your endocrinologist, right? So if you need your patient to do ACTH stimulation test, send your patient to endocrinologist. And if the cortisol after the ACTH stimulation is more than 18, it is normal. And if it is less than 18, that means the HPA axis is compromised, right? So this is a very, very important thing, right? So if you need to do ACTH stimulation test, you need to send them to endocrinologist. Now you have Synectin available in India, right? It's now available. So any endocrinologist of yours can do the test. It generally patient need not be admitted. You can do it as endocrinologist can do it as an outpatient or daycare procedure as well. So you can do an ACTH stimulation test while in daycare as well. So this is basically, I'll repeat this again. How do you diagnose adrenal insufficiency? So first step you do is morning cortisol. Okay. If it is less than 5, definitely adrenal insufficiency. 5 to 12, maybe. More than 12, normal. If the value is between 5 to 12 cortisol, then you have to do DHEAS ratio. If the DHEAS ratio is less than 1, definite. 1 to 1.8, maybe. More than 1.8, normal, right? And then if it is this value, then you have to do ACTH stimulation test, right? So the third step would be to do ACTH stimulation, and if the ACTH stimulation value is more than 18, it is normal, and less than 18, maybe, right? It is HPA axis input, so adrenal insufficiency, right? So these are the steps towards diagnosis of adrenal insufficiency. Now it's very important to understand that we talked about steroids, and most of us feel that injectable steroids or oral steroids lead to adrenal insufficiency, but that is not true. Even non-oral steroids can lead to adrenal insufficiency. So this is something important and all of us need to understand. So inhaled steroids, for example, we use these inhalers, fluticasone and all that, that can also lead to adrenal insufficiency. Rarely skin steroids also, very rarely. Intra-articular steroids, which are often given by orthopedic surgeon, can also potentially cause. Intranasal spray does not lead to any problem, and ophthalmic application generally does not lead to problem. So inhaled steroids can lead to adrenal insufficiency, and intra-articular steroids can potentially cause, but topical application may cause if the skin in certain situations, but not in all cases. Okay, so these are some things you need to be aware about. So inhaled corticosteroids, remember, it's very important to understand when you give an inhaled steroid, some of it gets deposited in the lung, some of it is actually absorbed orally and then can go to the GI tract, and it's like taking an oral steroid tablet. And remember, this inhaled steroids are taken frequently and for long period of time by patients, so it can lead to it can be absorbed in the systemic circulation and can compromise the HPA axis. So we have seen a lot of patients. This is the kind of patients that we see very commonly in hospital, where they are having COPD or asthma, and they have been taking steroid for a long time, and that ultimately leads to the system being compromised. Okay, so let's look at management of adrenal insufficiency. Now, we'll discuss the clinical features with the cases. So we'll come to the management here, right? So adrenal insufficiency, it's basically straightforward. When you have a patient who is having acute, this is not an adrenergic crisis or Addisonian crisis. So if a patient comes in emergency with adrenergic crisis, in this cases, when generally patient is in crisis, the patient is having hypotension, right? Low BP. Low BP, one of the major causes of low BP is adrenal insufficiency. So when a patient comes in acute crisis or adrenergic crisis, that time you have to give IV hydrocortisone, right? If the patient is in outpatient basis, then you can give oral hydrocortisone, Hyzone, which is available in India. So oral hydrocortisone is the mildest steroid available, or you can give oral prednisolone, right? Generally we have to give low doses. We start with generally 2.5 to 5 mg of prednisolone, right? So we have to give very low dose. In primary adrenal insufficiency, you also have to give fludrocortisone, right? So these are the two drugs. DHEA supplementation is debatable. We generally don't give, right? But oral hydrocortisone or oral prednisolone with fludrocortisone. Fludrocortisone is available as Floricort, right, in the dose of 0.1 milligram, right? So this is the dose. So that is generally you can give once a day. Okay. So if you have secondary adrenal insufficiency, again in acute crisis you have to give IV hydrocortisone, but in chronic cases again you have to give oral Hyzone or prednisolone, right? Some cases we give dexamethasone also, but generally we do not give it. Dexamethasone is a very potent steroid, so it's not to be given in all cases, right? So this is how you treat a patient with adrenal insufficiency. In acute adrenergic crisis, we generally give injectable hydrocort, right? Generally the doses either you give 100 milligram 8 hourly or 50 milligram IV 6 hourly. This is something you need to give IV. Okay. Now let's look ahead and let's look at some cases, right? So I promised you that the first part was going to be about the learning, didactic learning. The next part is going to be about cases. I'm going to show you some 3 interesting cases to help you illustrate the fundamentals of adrenal insufficiency. Okay, so let's look at the first case. So this patient is 40-year-old patient from Haryana. He presented to us with hypertension, weight gain, erectile dysfunction. So you can see this patient, right? So you can see classical features of Cushingoid system, right? So patient has moon-like face, right? What is moon-like face? When you see the patient from the front, you are not able to see the ear, right? That is the fullness over the temporal region. That is basically moon-like face that you can see over here. Patient having stria, you can see typical Cushingoid stria over the abdomen and over the axilla, okay? So this patient had Cushing syndrome. So you are saying Cushing syndrome is opposite of adrenal insufficiency. Why am I saying? Remember, this patient had, so when we took the history of the patient, this is another patient, we took the history of this patient, the patient basically had, right, okay. So, okay, let's go step by step, okay. So this is a patient who looks Cushingoid, right? These patients are looking like having Cushing, right? Now Cushing's is basically excess of steroid. So you will say that, Om, you are saying exactly opposite of what is happening. How is this patient having Cushing? Okay, so patient is having Cushing's. Now Cushing's can be endogenous or exogenous. Endogenous Cushing's means patient's body is producing more cortisol, okay, and because of that patient is having Cushing's. But exogenous Cushing, which is more common, is when patient is taking steroids from outside. Okay, so sometimes patient is abusing steroids, which is very, very common. You will be surprised how common it is. It's very common. So if the patient has been taking steroids for a long time, or patient has been given steroids by some doctor for a long time, that leads to exogenous Cushing's. And what happens when steroid is given for a long time? We discussed when prednisolone more than 20 milligram is given for more than 3 weeks, the HPA axis is compromised. So the patient who is on steroid for a long time and the steroid is suddenly stopped, the patient develops adrenal insufficiency. So when we looked at this patient, right, we did the test, we did the morning cortisol, and the morning cortisol was 1.8, 1.2, just 1.2. So we saw earlier less than 3 is considered to be low. So what is the diagnosis? The patient basically had, the complete diagnosis in this case would be exogenous Cushing syndrome with tertiary adrenal insufficiency. The patient is having adrenal insufficiency because of long-standing steroid use. So that is the diagnosis in the first case. I told you about exogenous steroid use, that when you are taking steroid from outside, that causes negative feedback on ACTH and CRH, leading to less steroid production from the body's own steroid production. So that is something which is very, very important, and hence that can lead to, in certain situations, adrenal insufficiency. Okay. So when should you suspect a tertiary adrenal insufficiency? Trust me, this is very, very common, right? And this is the thing which is so common that it is often missed out. Now, patient is taking any form of medications for diseases like arthritis, asthma, COPD, PUO. So a lot of times steroids are given. Patients may appear Cushingoid. Sometimes symptoms may be more subtle. right? So history taking is very, very important, right? But there are certain clinical signs which will help you. So patient has unexplained weight gain, patient has skin changes, stria, facial flushing, thinning of skin, which is all. Patient has osteoporosis, right? Weak bones. Patient has vertebral fractures. Patient has unexplained hypoglycemia, or sugars are sometimes very low, very high. Again, patient may be taking steroids, or very importantly, unexplained hyponatremia. This is very, very important. I'll show you another case later as well. Hyponatremia is a very important sign of adrenal insufficiency. Whenever you have a patient with hyponatremia, always in India rule out adrenal insufficiency, right? It's very, very, very important. Okay. So in fact, if you don't take any lessons from today's lecture, just take one lesson. Whenever you have patient with hyponatremia, rule out adrenal insufficiency. Okay. Again, you can simply do cortisol, right, or you can do cortisol plus DHEAs. Just do this test, and many cases you will pick up adrenal insufficiency. Again, if you are not sure, refer it to an endocrinologist. Okay, but hyponatremia always rule out adrenal insufficiency. So this is something which is very, very important. So how do you manage tertiary adrenal insufficiency? So patient is already having glucocorticoid excess, features of Cushing, but body's own production is less. So how do you treat that? So the problem is you have to give them low dose of steroid, right? This is, you will say again contrary to, but remember, patient has been taking steroid for a long time. Patient's own body steroid production is not enough. So that means you will have to give very low dose of steroid till the patient's own body steroid production recovers. This may take as much as 9 months to 1 year, right? So you have to be very patient in these cases, and you have to give it very carefully. And secondly, you have to remember that again, long-term steroid use, whatever complication patient develops, you need to treat their complication. For example, if the patient develops osteoporosis, you need to treat the osteoporosis. Patient develops high sugars, you need to treat the hyperglycemia, right? So that's the thing. Now let's look at the second case, right? And this is a very beautiful case that illustrates how even in sophisticated setups, you have this diagnosis being missed out. So this is a 57-year-old male patient who presented with complaint of fever, vomiting, loss of consciousness, right? So this was the history, and on evaluation he had hyponatremia, right? This is, like I said, very, very important such thing that I told you, right? So he had hyponatremia. Sodium was only 129 at the time of initial presentation in the emergency. Now prior sodium, right, was done a 1 month back at the part of health checkup. It was 135. So 1 month back sodium was normal. Now it's suddenly dropped to 129. Okay. Now patient had similar illness in the past also. So whenever the patient had some kind of fever or some other situation, the patient would develop low sodium, right? So patient had recurrent hyponatremia in the past also. Okay. So this is a very typical history. Now the patient's daughter was a physiotherapist or something, and she had noticed that every time the patient had developed fever, the patient would develop low sodium, right? So patient would develop hyponatremia whenever he had fever. So this is something which was very typical history. Okay. Patient was also having hypothyroidism, for which he was taking levothyroxine 50 microgram. Again, he doesn't remember when it was diagnosed, but he has been taking levothyroxine for a long time. So in the emergency, somebody sent the osmolality, serum sodium, all this fancy tests were sent, right? And patient was given hypotonic 3% saline, and after the sodium went up, the patient regained consciousness. Now, interestingly, when the patient regained consciousness, we took the proper history. The patient has history of pituitary surgery. This is something very, very important, right? So patient had undergone a pituitary surgery, right? So the pituitary gland was removed, right? And if you go back to our understanding of the HPA axis, what you remember is that, right? Again, I'll draw this, right? So you have the hypothalamus-pituitary-adrenal axis. Now, what if somebody removes the pituitary gland, right? What will happen? Will ACTH be produced? No, right? ACTH will not be produced, and because ACTH is not going to be produced because pituitary gland is removed, how will cortisol be produced, right? So cortisol will also not be produced. So hence the patient will have adrenal insufficiency, and this is a classical example of secondary adrenal insufficiency, right? Where because the pituitary gland was surgically removed, patient doesn't have enough steroid production for the own body. Now, pituitary surgery, if you have seen being done, the entire pituitary gland is not removed, some part is retained, right? So patient had some pituitary gland which was remaining, that was enough to carry out day-to-day function. But remember, cortisol is a stress hormone. So when the patient develops physiological stress, for example, whenever the patient was developing fever, at that point of time the body's requirement of the steroid increased. But because the pituitary gland could not produce enough ACTH, the patient would develop adrenal insufficiency. So this is exactly what I told you right at the beginning. So this is something which is very, very important to understand. So whenever the body's requirement of steroid increases and the body is not able to match up with the production, at that point of time the patient can develop complications. So this is what happened to this patient, right? That in general cases the patient was fine, but whenever he developed fever, he would develop adrenal insufficiency and then he would develop hyponatremia, and that hyponatremia would lead to the complications which he had coming to emergency. So this is typical cycle, and this is what his daughter noticed, and that's why it was a very important part of history which was there, right? Now patient had undergone pituitary surgery long time back, even before his daughter was born. So even his daughter did not know that history very well, but patient clearly gave that history, and we did the MRI. The MRI showed empty sella, right? So pituitary gland was removed, right? So there is known as empty sella. Sometimes there are certain patients who for some other reason develop empty sella. So that also is secondary adrenal insufficiency. Even snake bite, viper snake bite can produce empty sella, right? So this is something which is important to know, right? So when you have such history, always look at the cortisol, and we sent the cortisol of the patient. So we got endocrine consult was done. Now we took at the patient's reports, right? And let's see, yeah. So I told you adrenal insufficiency is a very important cause of hyponatremia, and sodium is typically low. Okay, so let's go to this, right? Yeah. Let's forget these things. Yeah. So we did the cortisol. In cortisol was 6. So I told you this is where that 8 cutoff is very important, right? So I told you if it is less than 5, likely, but 5 to 12 maybe. Okay, the patient had value of 6. The free T4 was also low. That was because of the again central hypothyroidism. If you remember our last talk which we had given about thyroid, I told you about central hypothyroidism, and TSH was normal. So forget that. At that point of time, cortisol was 6. But because patient had hyponatremia, we did ACTH stimulation test, and ACTH stimulation test at that point of time came to be 10, which is low, right? It should be more than 18. Okay, so that was not there. So hence we label this patient as having adrenal insufficiency, and the patient was given glucocorticoids, right? So I told you about how to do the diagnosis, I think. So we already discussed this point, right? So the patient was started on initially injectable and then oral hydrocortisone. The patient was doing very well and patient is fine. Let's look at the third case. This is a case which we had published as a case report. So this case report is available. This was published in Thyroid Research and Practice. So this is again a very interesting patient who came to the emergency. So 22-year-old male patient had history of significant weight loss, and hence it is very important. Weight loss is a very important history of adrenal insufficiency. Okay. So whenever you have a patient complaining of weight loss, you should look at adrenal insufficiency. The patient had about 15 to 18 kg weight loss. Now patient typically, if you saw, had darkening of skin and oral mucosa, right, over that period of 1 year, right, and along with generalized fatigue. So these are the symptoms of the patient. This is what the patient looked like. You can see the darkening of the skin and the oral mucosa, and the patient overall looks dark. Okay. So prior to the admission to the hospital, patient was admitted 3 times in the span of 1 year, each time with vomiting, diarrhea, and patient was found to have hypotension. Earlier also I told you hypotension is again an important sign of adrenal insufficiency. In the third admission, somebody did a thyroid function test, and that time patient was found to have hypothyroidism. The patient was started on levothyroxine. The problem is, as soon as the patient took levothyroxine, the patient actually within a day became worse and came to the emergency department. And when the patient came to the emergency department and we saw the patient, immediately we recognized that the patient is having adrenal insufficiency, right? So patient basically had hypothyroidism also, but patient also had primary adrenal insufficiency. So typically that was the thing. So you look at this patient's lab report, again you can see hyponatremia, right? Initial presentation, patient had hyponatremia, patient had potassium of high, right? So in primary adrenal insufficiency, patient typically have hyponatremia with hyperkalemia. So that is very typical. You can see here the TSH was also still high, right, despite replacement, and ACTH you can see was very high. Remember, this is negative feedback, right? So when you have low cortisol, and low cortisol is produced by the less of adrenal gland, less production, then ACTH increases, right? So that is the thing. And if you see the cortisol level, very low, was 0.68, right. So this was the very classical diagnosis. So made this diagnosis. Patient basically had what is known as APS. APS is basically autoimmune polyendocrine syndrome, where you have multiple endocrine organ involved. The patient had APS type 2, which is basically adrenal insufficiency with autoimmune thyroid disorder, right. So that is something, even with type 1 diabetes also this can exist. So this is something which is important. So how do you diagnose? What are the clinical features of adrenal insufficiency? The clinical features of adrenal insufficiency: patient will have a history of nausea, vomiting. Patient can have hypoglycemia, fatigue and weakness. If it's an infant, it can be failure to thrive, morning headache. These are all symptoms, right. Patient can also have hypotension, I very important told you, dehydration, salt craving, muscle weakness, weight loss, right, GI symptoms and electrolyte imbalance. These are all signs. Remember, glucocorticoid is cortisol. So when you have adrenal involvement, you have both cortisol deficiency as well as you have mineralocorticoid, which is aldosterone. So you have deficiency of both, and generally the clinical features are mixture of both, right. So you will have mixed clinical feature of both the deficiencies, and in primary adrenal insufficiency you have to replace both these hormones, right. So this is the clinical presentation of adrenal insufficiency. So I told you, I'll tell you this in the end, because once you look at the cases, you'll realize how how these patients typically present. So just to summarize, an important take home message, right. Always remember, suspect adrenal insufficiency when you have a patient with unexplained weight loss, unexplained darkening of skin, hyponatremia, very very important, hypotension. These are all important causes of adrenal insufficiency. Do a baseline cortisol, and again these values I told you, it is changed less than 5, right. Definitely think of adrenal insufficiency. Less than 3, it is 100%, right, adrenal insufficiency. ACTH is a useful test to differentiate between the different types of adrenal insufficiency, but it's not important at a primary care level. Let that be left to endocrinologists to make that diagnosis. What you need to understand, just make the diagnosis of adrenal insufficiency, that is more than enough, right. And if you do that, you will save a lot of lives. And DH is a very important emerging test for diagnosis of adrenal insufficiency. And so these are the very important messages. And finally, refer all cases whenever you have a diagnosed case of adrenal insufficiency. Always refer it to endocrinologist, right. That is 100%, because if you see from these cases also, you realize that not many other specialties understand adrenal gland as well as endocrinologists do, right. So this is the my presentation. Thank you for a patient listening. Just a few announcements I wanted to say. As a lot of you would know, I do a lot of things with artificial intelligence. We do a lot of AI things. So we are having a workshop, free workshop for use of AI for artificial intelligence for research, right. So we are going to develop an end-to-end clinical paper using AI, right. So this is there on 15th of August. It's a holiday for all of us, it's free, so you can register. This is the link for registration. The QR code is there for link for registration, so you can register for this workshop. If you want to send a patient for an online consultation, I'm sure a lot of you who will be listening may not be in Ahmedabad, so this is the QR code. You can send the patient for online consultation with me. And we are developing something called technochronology.com. This is a tool for these are a suite of AI tools for doctors. Again, if you are interested in something like this, again you can look at the QR code, and you can scan this QR code to check this out. I'm there on Twitter, and you can follow me on Twitter. Dr. Pragnesh and me are connected on Twitter and also on LinkedIn, right. So this is another place where you can connect. So these are ways of connecting with me on your if you have doubts and queries, I will help you out for that. So thank you for a patient listening, and we'll be happy to take any questions if there are any.